Hi there. I'm so excited to welcome you to the Arthritis Life podcast, where we share arthritis life stories and tips for thriving with autoimmune arthritis. My name is Cheryl Crow, and I am passionate about helping people navigate real life with arthritis beyond joint pain. I've been living with rheumatoid arthritis for 20 years, and I'm also a mom, occupational therapist, video creator, support group leader, and I created the Room to Thrive self-management program. I am so excited to help you live a more empowered life with arthritis. We're going to cover everything from kitchen life hacks to navigating the healthcare system to coping with friends who just don't get it. Seriously, no topic is going to be off limits on this podcast. My interviewees and I share our honest stories of how chronic illness affects our lives. This includes discussions about mental health, sex, shame, pregnancy, body image, advocacy, self-acceptance, and so much more. You'll hear stories from all ends of the spectrum, from a person who's living in medicated remission from psoriatic arthritis to somebody living with severe mobility restrictions and severe pain from rheumatoid arthritis. You'll hear how people manage their conditions in different ways, like medications, mindfulness, movement, social support, work accommodations, and so much more. You'll also hear from rheumatology experts who just get it. We'll dive deep into the science behind chronic pain and what's the latest evidence for lifestyle changes that can help you thrive with arthritis, including exercise, sleep, nutrition, stress reduction, and more. This is your chance to sit down and chat with a friend who's been there. Ready to figure out how to manage your arthritis life? Let's get started. All right, I'm so excited today to have Dr. Julius Birnbaum with me. Welcome.
Oh, thank you for having me.
It's so great to have you. And I just thought it'd be good to give a quick introduction. Where do you live and what is your relationship to inflammatory arthritis?
Where I live right now in Wexford, Pennsylvania. I grew up in New York City. I've lived in virtually every borough there. And I'm still a diehard Yankees fan, which doesn't sit too well here. And my experience with arthritis is I just keep learning from my patients. And every year I think I evolve and find another area interesting. So I'm just very passionate about very broad areas of arthritis.
That's wonderful. We need all the help we can get. I think I speak for a lot of the patients. And I think I'm always really fascinated what makes people choose of all the different medical fields, what makes a medical student or doctor choose to specialize, in your case, not only rheumatology, but also neurology. Can you tell us a little bit about that process? What drew you to those fields?
Oh, sure. So I'm a neurologist as well as a rheumatologist. And I think what often is not known is that when you're a medical student, you do rotations and you're asked to make career decisions after rotating 5 weeks on a certain rotation. And so it could be difficult. So I loved neurology. What I liked about neurology is you can take equipment that's been around really since the early 1900s, and you can localize a certain injury. Is it in the brain, the spinal cord? It's very powerful, and this was all done before the years of MRI machines. I loved internal medicine as well. I've loved how, whether you're an internist, you could try and take care of patients with heart disease and lung disease. And it's that ubiquitous nature of internal medicine that I also found really enthralling. So for someone who has difficulty making decisions in general in life, that was something that was challenging for me. So I started neurology. And what I found was that I love doing the neurological examination, but loving to do the examination for what purposes and what diseases. And what I found was that as I got later in my neurology residency, I found that I found it fascinating to take care of patients with autoimmune diseases. And I started seeing patients with neurological complications of rheumatoid arthritis, how rheumatoid arthritis can affect the cervical spine. So there was this interface between neurology and rheumatology that I really was excited about. And I really felt that rheumatology was an area that I could grow, learn about autoimmune diseases, and use my training in neurology to also particularly help patients with neurological complications of inflammatory arthritis.
That's really wonderful. I mean, I think it's such a diamond in the rough situation. I think a lot of patients, they wish they could have doctors that specialized in multiple things to see. Like, I know when I was pregnant, I'll just say, I wished like somebody was a specialist in both OBGYN and rheumatology. Because sometimes when you have multiple things going on, you feel like they're giving you opposite.
Yeah.
Sometimes, and it makes sense. I mean, OBGYN is a unique case, right? Because there was the pediatric side of like keeping the baby safe. There was the rheumatology side, keeping me safe. And everyone had different opinions. But anyway, that's my story. But back to your story, I think that's really wonderful. And the cervical spine, for those listening, just in case I was trying to define terms, that's like your neck, essentially. So
Yes.
it's less common with people diagnosed in the last 20 years to have severe complications that affect their cervical spine, I've heard. Is that right?
It is. And that's because within the past 20 years, arthritis is treated so much more effectively. So if you go back 20, 30 years ago, I actually have, my father was a physician, so I have his Bates textbook of physical diagnosis and what rheumatoid arthritis looked like in the 1970s. And then you saw a lot more spinal cord disease, just because that occurs when there's a lot of inflammation that goes undertreated. So we're seeing that less often today than we used to.
Yeah, and I always try to sprinkle in that historical perspective because I think I get why patients are scared to start medications or treatments, but I think understanding how transformative they've been and how dangerous the disease is if left uncontrolled it helps me feel more confident personally in taking my medications. But back to this combination of kind of having the neurology perspective and the rheumatology perspective, one of the things that before we started the episode, we talked about what are you most passionate about and what are some things that you love discussing. I think the diagnostic process is such a fascinating one in rheumatology. I would love to hear more from you about what are the steps you go through when someone comes into your clinic and you suspect they might have some form of inflammatory arthritis. What's that process like from your end?
Sure. So I think it can seem a little bit naturally like intimidating at first because we don't have any tools like a blood pressure cuff that's going to tell you within 30 seconds whether you have high blood pressure. You're not going to have a throat swab to tell you within 15 seconds that you have a strep throat. But there are certain patterns that we follow. For example, when we think about whether someone has rheumatoid arthritis. So I'm going to be carefully listening to your symptoms. And I want to find out, is the pain called inflammatory joint pain? So inflammatory joint pain tends to be the pain which is worse at rest, get better as patients move around. Non-autoimmune or mechanical pain gets worse with activity. So I want to see in the get-go, is this possibly symptoms of an inflammatory arthritis? So we move from symptoms, then we use physical examination techniques. So I'm going to press over joints and try to figure out, are the joints tender? Are they swollen? Are they slightly red? And these are diagnostic tools on the examination that goes along with symptoms. And then the last part of it is I'm trying to understand whether there's inflammation, whether there's blood markers of inflammation that are high, whether there are other markers of an autoimmune disease in the blood. So I think it's pattern recognition and how these are assimilated. It's based on your symptoms, based on your physical examination findings, and based on blood work. And again, this is very powerful because it offers a way to render a diagnosis, but in a very patterned way that's organized and efficient.
That's really helpful. And I think for any patients listening, sometimes I have people listening who they suspect they might have some sort of inflammatory arthritis, like rheumatoid arthritis, but they're not sure yet. Little tip I always say is really start paying attention to those patterns of the pain. When is it, like you said, when is it worse? Is it worse at rest or is it worse when you move around? Is it worse in the morning or worse at night? those things that seem maybe small to you are really helpful to the rheumatologist. Is that right?
It is, and it's really incredible to think about how your bedrock of symptoms are always going to remain the thing that drives the diagnosis. So we can have blood work now in 30, or actually, and maybe in the next 10 years, we'll have gene chips, which will tell us more
Mhm.
quickly, like what treatments might be more efficient for you. But what's never going to go away in rheumatoid arthritis is a physician carefully listening to your symptoms. So it's such a powerful thing to remember that the way you articulate your symptoms is really going to still be the centerpiece of the diagnosis.
Yeah, that's really powerful. And one of the other things that I remember my rheumatologist, I mean, this was over 20 years ago in my case when I got diagnosed, but it was, is it happening on both sides of your body? I know, like, that's what you're doing when you're doing the physical exam, but that's a big differentiator between maybe an injury causing just one joint being swollen on one side of the body versus both sides. Is that correct in your experience?
Yeah, so exactly. Rheumatoid arthritis is definitely more likely to be symmetric, affecting
Mhm.
the left and right side of the body. And but that's what I mean. That's what makes rheumatology so interesting is that, and I find it really fascinating that we're going to go into new ways of helping you care for your disease. But again, the thing that's not going to go changing now is how it presents, how you describe your symptoms, what your
Mhm.
examination will feel like. I mean, boils back to the point that we need to listen to you
Mhm.
as patients, and that's not going to be supplanted anytime soon.
Yeah. I love that. And how maybe I'm curious how you do what I guess they call it the differential diagnosis, like between maybe you suspect there's some sort of inflammatory arthritis. How do you differentiate between whether it might be rheumatoid arthritis versus psoriatic arthritis versus ankylosing spondylitis or something else?
Sure. So again, it's recognition about patterns. So like you were mentioning, rheumatoid arthritis, it tends to more often than not affect both sides of the body. It can affect one side of the body sometimes, but what we describe as symmetric right, left side being equal is more common. In a disease such as psoriatic arthritis, there are different patterns. Most of them will be different. So there can be just a few joints that are affected, maybe three or four or less, when rheumatoid arthritis tends to affect more joints, for example. In psoriatic arthritis, you also have inflammation of tendons and ligaments that insert on muscles, and that's given a term, it's called an enthesitis. And that's not really seen in rheumatoid arthritis. One
And
of the
that's
things,
that sausage finger. It kind of is that the result of that?
so right, and then the next thing you
Oh, so,
develop,
oh, sorry, I didn't mean to jump.
yeah, but that, no, so this is the thing, right? You first show it to medical students, and this kind of like whets their architect appetite. Is the sausage finger? So this is not just one joint swelling up; it's the entire finger or toe that's swelling up, and that's like called the sausage digit or the dactylitis. Psoriatic arthritis, you're have a higher likelihood not only to develop psoriasis, but certain inflammation in the gut diseases and eye diseases. So I think that psoriatic arthritis has a lot more pieces to it compared to rheumatoid arthritis, but it's really the presence of asymmetry. It's obviously the presence of the rash and other findings as noted above. Ankylosing spondylitis is just as painful, initially starts as back pain. And again, it's what we've been talking about, the back pain that we see not due to autoimmune component get worse as you bend over, as you use it. And then the ankylosing spondylitis, it's worse with inactivity, worse in the morning, gets better as the day goes on. So different diagnoses. But I find that when you can talk about patterns of these diseases, then it's something that the patient has a better handle on to understand windows into their own disease.
Yeah, 100%. And I had an experience recently that I wanted to share really quickly that relates to all this because you can also have, if you have one established form of inflammatory arthritis, like I have rheumatoid, you can also have joint pain in a different non traditional area, but that's not from that disease, from either an injury or an overuse kind of inflammation, tendonitis type thing. So I started running this year again, which I hadn't run in a long time. I used to be a soccer player and a runner. And then I started having hip pain, and I was doing my own little differential diagnosis in my head. And I was like, this is definitely not rheumatoid arthritis. First of all, it's my assessment. It was only on one side. It didn't feel like it was in the ball and socket joint. It was like more kind of wrapping around from my hip bone to like my glute. And it wasn't noticeably worse in the morning. It was worse with activity and worse with and it was like came on extremely fast. Like went from just a little bit of like this muscle's something's kind of tight there to being like, I can't even roll over in bed comfortably. So I went to a physical therapist, and she did a great assessment and realized that, yeah, I have some joint sacroiliac inflammation, most likely from just really not great posture. Like I have a little bit of a pelvic asymmetry, some muscle imbalances around it. Anyway, point being, this is not related to my RA that we can tell right now. And it responded really well to the physical therapy exercises. And when I shared about this in my Instagram stories, someone said, well, wait, I thought if you had hip pain or axial pain, then, spine pain, then that means you must have AS or you must have spondyloarthritis, but not all back pain or spine or hip pain is from AS. Does that make sense? Sorry. Long story
It does
short.
make sense. And so the book I've written, it's called Living Well with Autoimmune Diseases, a Rheumatologist's Guide to Taking Charge of Your Health. I think that's the first goal, because like you're saying, joint pain can be due to a variety of causes. So that's the very, very first step. You're saying, am I having joint pain due to an autoimmune disease, due to inflammation, and like you're describing, or am I having joint pain due to another cause? And that's the very, very first step that physicians think about right off the bat, inflammation or not inflammation. Yeah.
Well, that you perfectly led to my next question, and which is, you asked me before we started recording, you said, oh, you probably define this all the time, like what is an autoimmune disease and what is inflammation? And I actually had to look at my records and realize we haven't actually defined on this podcast in a while what inflammation actually, what is an autoimmune disease? What is inflammation? I mean, partly I feel like they ought to read your book, but also maybe what, in your words, how do you explain that?
No, that's a great question. When we talk about inflammation, there's inflammation that's helpful. So we get a cut, and then the inflammation that happens afterwards, where the cut turns red or warm, that's inflammation that's protective. Inflammation that's excessive and is not dammed down a little bit, when it goes too awry, that's what we call harmful inflammation. Now, when we talk about autoimmune diseases, what I often like to tell my patients is that we normally have an immune system that helps us. It normally fights off infections. It could fight off cancers. But in autoimmune diseases, the immune system can become confused. And instead of being helpful in this way, it could target different parts of our body. So, for example, in rheumatoid, psoriatic arthritis, ankylosing spondylitis, those are cases with the immune system, in addition to fighting off infections and cancers, it starts affecting different parts of our joints.
Mm-hmm. Yeah, and just to put the immune system in the context of inflammation, when you were saying that, like when we get a cut, it turns red and warm, and that's like a protective response. That is our immune system driving that response. Is that right?
Yes, it is. So that's the very, very first part of the immune system. It's called the beginning stages is the innate immune system. It's what we share with single cells of bacteria that very primitive. You get into a cut, and it's called almost like a flight or fight response, and it's help me, alarm. And there's that first stage. So yeah, that type of inflammation is at the beginning of the cause of different types of arthritis.
Yeah, I think that's it's really helpful to kind of get clear on these definitions and understand that it's almost, I try to imagine the disease process happening in my body in a bit of a self-compassionate way, because I know a lot of people feel like my body's attacking myself. Like my body's broken. It's doing this terrible thing, which it's in whatever works for you. For me, I think of it as it's kind of like a toddler that's trying to help you in the kitchen. When you have a toddler that's like, I'm going to help you bake that. And they're like spilling the flour and like
Right.
breaking the eggs. I try to think of it in that compassion way. Like it's trying its best. It just accidentally decided that the synovial lining of my joints is a virus. And it's like, we're going to get rid of that. We're helping you. And that's for me, that is maybe it's just my personality, but that helps me feel less like, oh, right, I'm the basically like this horrible thing is happening in my body. Obviously, I don't like it. I would like it to be gone, but I'm like, oh, okay, it's trying its best. It just made a mistake.
Yeah, no, it's interesting you say that because I purposely, when people ask what an autoimmune disease is, I always say an autoimmune disease affects different joints. I don't say it targets different types of joints. I don't say it injures joints because then you have this image of a military battle being fought and won, and are you being like victimized by this? And I kind of want to paint it that there's an autoimmune process that's going on. It's affecting joints, but it's not because you're weak or you didn't do anything wrong. It's not being attacked, it's affecting. And I think if you start, like, I think it sounds like you're doing the same thing, viewing it in a more compassionate way, then that helps you get to a blame yourself less and don't worry about like what you've done that you're culpable in having this disease.
And that, yeah, you again read my mind. My next question was going to be that a lot of people, and again, maybe I joke that I'm like a product of the 1980s parenting style that was self-esteem movement, like tell your kid they're special 9 times a day and they think they're special. So I didn't like, like a lot of Mr. Rogers' Neighborhood, like, I
Yes.
love you. So I internalized that. So I didn't blame myself when I got diagnosed. It also for me seemed absurd to blame myself because I was at the peak of health. I was the captain of my college soccer team, now Division III, but still I was very healthy, very athletic. Nothing, no aces in my childhood, no rhyme or reason as to why this happened. It just, as far as we know, it was genetic susceptibility met some sort of environmental trigger. Probably just I got a virus, some virus, and probably then that maybe, who knows? It's just random for me that I didn't blame myself, but a lot of people do end up blaming themselves. When you have those conversations with your patients, like how do you help them think through that, I guess? Or do you have time to
Well,
in your appointments?
so yeah, I mean, basically what you just suggested is the way I try to explain it to my patients when they're asking like, what causes autoimmune diseases? And the answer to that is going to win a Nobel laureate prize. But that doesn't prevent someone from understanding that if you want to think about autoimmune diseases in ways that are simplistic, but are actually very powerfully from a scientific way, it's basically a genetic predisposition. There might be an infection. There might be some environmental influence. It's pretty much what you're saying. It just brings up the point that when you have inflammatory arthritis, it's not a single thing that's the cause. It's what we call multifactorial, a lot of different elements that contribute to it. So that's why a lot of times I get the questions, is it a genetic disease? And it's not a genetic disease in the sense that your son or daughter is going to develop it. It's just that there are genetic predispositions, but lots of other things go into whether you develop an inflammatory arthritis.
Yeah, yeah. I think that's really helpful to remember. And I think another area of confusion is just because certain lifestyle choices you make might, let's say you choose to adopt an anti-inflammatory diet or eating pattern, or you choose to exercise and that's kind of helps tamper down that inflammation. That doesn't mean that your failure to do those things before your diagnosis caused it either. Do you know what I'm saying? Like it's kind of a confusing thing for people sometimes.
Yeah, but it's a natural thing because I think when you go back and if you have high blood pressure and let's say you had a high salt diet, then there's a
Mhm.
direct link. But yeah, autoimmune diseases are complicated enough
Mm.
without trying to like search and claw away for your own history saying, aha, that's the moment or this is the
Mhm.
instant. It's just, if we knew directly how to cause it, then we'd be able to cure. But we can still use therapies can be enormously powerful and immeasurably help your quality of life.
Yeah, yeah. And I wanted to just go into your book a little more before we're gonna talk about advocacy, self-advocacy, and that's you have a great set of perspectives on that from both sides, provider side and your family story. But I want to make sure to mention that your book it's about living well with autoimmune diseases. So it's not just rheumatoid arthritis, which is obviously my specialty and my personal interest, selfishly, but also vasculitis, lupus, Sjogren's, fibromyalgia, psoriatic arthritis, myositis, scleroderma, which I do have a blood relative that just got diagnosed with scleroderma. I have one blood relative, great aunt, that had juvenile idiopathic arthritis. And then so those are the only two of all my extended family, lots of cousins, lots of aunts, uncles. It's interesting how there's only a couple. But anyway, but you're back to your book, you walk people through not only like what is inflammation, like we just talked about a little bit, but also how do these treatment options work and how do you decide as a provider, like when to introduce like immunosuppressive therapies and why they're necessary. Oh yeah, that's another question or thing that I think something that again, tell me if the way I'm visualizing this is correct. I obviously don't like the concept of being immunosuppressed, but one of the things that makes me feel more comfortable with it is that my immune system was already doing too much of something. So it's not like you're taking a normal amount and suppressing it. You're taking too much and reducing it. Is that correct? I'm honestly asking that. Is that helpful or am I oversimplifying it maybe? Or
No, I think it's perfect.
Oh, okay. Well, give me a gold star. Yay.
Yeah, because you're pointing, I think it's really important because a lot of times when it's the vocabulary. So if you hear like immunosuppressive medications, people or patients naturally get scared. And what I tell patients is like what you're saying, we're targeting excessive inflammation, but you still have an immune system. Now you're more prone to develop an infection. Yes, but your immune system is still pretty good at being able to care for itself. So we're not taking away your immune system. We're just taking the edge off the harmful part of the immune system that's contributing to your disease, but you still have an immune system that functions.
Yeah. I think that was really helpful for me getting through the COVID initial time without my anxiety going too far ahead of me because I had so many experiences already. By the time COVID started, I had my rheumatoid arthritis for 17 years. And so I had a baby and I had gone through postpartum flare, but I'd gotten the flu here or there. And I noticed, I take a little longer potentially than someone like my husband. A lot of us are married to people who, at least I noticed in my support groups, married to people with unusually robust immune systems. It's like, come on, give me some of yours. But it takes me a little longer. Things linger like sinus infections and stuff. But it's not like I was walking around feeling like I was swing dancing, touching a lot of people, breathing on a lot of people, and not getting deathly ill on the amount of immunosuppression with methotrexate plus a biologic. So, but I know with people diagnosed during the COVID times, I think it was a little bit more scary for them just because you haven't experienced surviving your first infection on your medication yet, right? So yeah, like it's like that thing, like I've survived 100% of my worst days. Like I've survived all this stuff. But yeah, okay. I'm glad that my immunosuppression metaphor makes sense to you as well. And I had these two researchers from Benaroya Research Institute here in Seattle on the podcast, Dr. Dave and Dr. Campbell, and they went into some great explanations on this. One of them is a PhD in immunology research, and the other one is a rheumatologist who also does research. And they all link to that episode here, but they talked about how there's still something unknown about why you might have 100 patients on the same medication regimen for the same diagnosis. One of them is a kindergarten teacher and never gets sick. Someone else works from home and they keep getting sick. Like they don't really understand sometimes why the same amount of immunosuppression doesn't, like on paper, results in different amounts of functional illness. Does that make sense?
Yes.
Kind of why I'm like, power to anyone out there who became a rheumatologist. I feel like that would be I think that's the hardest field of all medicine. I'm going on the record. No one asked me, but I'm like, why would you choose? I mean, I'm so glad you did. But when I ask rheumatologists why did you choose it, they usually say something similar to what you said, that it's so interesting. Like it's not black and white. Is that kind of what drew you to it? If you have ever felt completely lost or utterly alone while trying to navigate real life with rheumatic disease, listen up. I am here for you. I created an educational program to help you go from overwhelmed to confident, supported, and connected in a matter of weeks, and it's called Room to Thrive. After earning a master's in occupational therapy and completing hundreds of hours of additional training, I created a step-by-step guide to help you truly thrive with rheumatic disease. This is the only program I know of that's designed to improve quality of life for people living with inflammatory, autoimmune forms of arthritis, like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial spondyloarthritis, Sjogren's disease, and more. During the self-paced lessons, you'll learn how to manage pain and fatigue, cope with stress, navigate relationships, and continue doing the things that matter to you and bring you joy. The goal is really to help you improve your quality of life and learn how to thrive with your rheumatic disease right now, rather than waiting for a distant day when it might be cured or healed. I really created the down-to-earth, practical, heartfelt resource I wish I had had when I was first diagnosed at age 20. If you want even more in-depth support, you can join the 12-week Room to Thrive virtual support group, where you'll be surrounded by people who actually get what you're going through, people who will provide the encouragement, validation, and support that you deserve. Each group is expertly moderated, so you don't have to worry about the kind of misinformation that spreads like wildfire in the free-for-all social media groups. If you're on the fence, don't just take my word for it. Here's what Katie had to say in March 2023. I was lost and overwhelmed with my RA diagnosis. It felt overwhelming to know what to read, what to do, how to spend my energy trying to research on the internet. Room to Thrive did that for me. It's been like getting a crash course in my diagnosis along with a community who gets it. To see all the details, including the dates for the next support groups, go to the link in the show notes or bit.ly/thrive room with a capital T and capital R. You can also just email me anytime at info@myarthritislife.net. And don't delay if you're interested, because each group is capped at 16 people or less in order to make a small, intimate group atmosphere. Thanks so much for your time, and I can't wait to get started with the next groups. And I can't wait for those of you who are interested in the self-paced option to go ahead and join that at any time. Bye-bye for now.
It is, because there's a lot of nuances to the disease, because if you're curious, you get to understand and explore what autoimmunity means, and that's fascinating. You learn to take care of patients with a lot of diseases that you might not encounter that much during your training, and that's interesting. But then the last piece of it is you get to absorb all of this scientific knowledge, and the way you apply it to help individual patients, that's just fascinating, because seeing how the disease plays out in different patients, that's something that's important, because that enables you to help them and empower patients to develop a personalized treatment plan. So it's the fascination with the disease and the ability to then take your understanding and how you can help patients.
Yeah, I think that's beautiful. I know you talk about that in the book too, about the importance of really developing a personalized treatment plan, because you probably heard this already if you're listening to this podcast. There's no one size fits all
Right.
in anything, but especially rheumatology, it feels like. How do you as a physician cope with the uncertainty? The uncertainties are all the gray areas, like that knowledge of, okay, I'm giving it my best. Because you don't have that blood pressure cuff or that, like, I don't know, A1C where you're like, it's diabetes or it is not diabetes. Like, you don't have that silver bullet. How do you cope with all those ambiguities, out of curiosity?
Well, it's a good question, because I think from a research standpoint, there's a term used that's called classification criteria.
Okay.
And these are criteria that's used to help researchers during the conduct of clinical studies. But then there's the other aspect of it, which is called diagnostic criteria. And those are criteria that you use to diagnose different types of autoimmune diseases like inflammatory arthritis. So you have to develop your own sense of understanding and appreciate nuance, because you could take some of the criteria that's used for research purposes, but then the way you deal with that in diagnosis is having a one-to-one discussion with the patients. And I always tell my patients, if they come in, they're like, well, I meet 5 out of 7 criteria, but the criteria say I actually have to meet 6 out of 8 criteria. And I just tell patients is to a certain extent, these criteria are oversimplifications. And in real life, not everyone gets put in a certain diagnostic box. So there has to be a lot of latitude in how these diseases are diagnosed. So I think that then, but again, a little bit of nuance makes it a very fascinating disease, and also helps the patient understand that they have ownership of their disease and they have a real autoimmune diseases, even if it doesn't meet all the criteria.
Yeah, yeah. I think that's really helpful. I think what I would struggle with is like, this is again, maybe me having an anxiety disorder, but I would feel like I would be haunted by this idea that what if I got it wrong? Like, what, and I know you've obviously accrued many years of experience at this point. So maybe you have more, just built more confidence, but I feel like maybe a new, like, do you find with the fellows and like your newer rheumatologists that did they, or maybe they just self-selected into here because they have good ambiguity tolerance themselves? But I feel like it would be just be hard to feel like, "Oh, like, what if it's something else? Like, what if it's lupus?"
Right. Well, it is. I think it's interesting because I think the fellows at the beginning of the year, they want to get everything right.
Mm,
So they kind of come at diseases like there's a recipe, for example. And I
mhm,
think you need that in the beginning, but once you become more experienced, you understand like where the gray areas are, and
mhm,
where is the uncertainty, and not to penalize the patients because they don't fit all of the criteria. There is a certain amount of certainty. So you want to know the traditional recipes, but then over time, you want to also get a sense of how to validate the patient as having a disease, even if all the parts of the recipe don't go checked off. It's a very much humane, as opposed to just a scientific field of medicine.
yeah. Well, that leads perfectly to the next topic I want to talk about, which is something you've spoken a lot. You volunteered your time many times speaking with like the Autoimmune Association, and you have a great video I'm going to link in the show notes about partnering with your doctor. And I would love to hear more about your perspective about how patients can advocate for themselves within that patient provider relationship and explore some of the themes, like you mentioned before we start talking, the themes of disempowerment and how do we navigate all of that? And are we, your own personal story, however, makes sense to you? I'm sorry, that was like a 9-part question.
No, no, it's interesting because like I've heard this before. I haven't known this before as an author, but how someone could write a book and have a message which seems so obvious to readers, but was not obvious to me in writing this book. So I wanted to inform, I wanted to help patients, I wanted to come across as someone of empathy. But what really I think has resonated is patients, they tell me that this is a book about empowerment. And I was like, really? Because I didn't sit there consciously say I want to empower, I want to help. And they're like, oh, this is a book about, someone's told me autoimmune empowerment. And when you hear these themes, and I was thinking about it, it's like, well, what's been at the back of my mind growing up? And I realized that there's times that I felt disempowered in my own life, and I felt pretty like angry about it. So I have an oldest son who has autism, and I remember he's 17 now and he's driving, doing great in high school. But when he was in first and second grade, and there were some behavioral difficulties. I remember that the school system basically wanted him put into classes where he would be basically fine from a behavioral perspective, but no one would be challenging him academically. And it could be pretty contentious, like where they wanted to silo him. And I know where my son's gifts lay, and I just wanted that to be uncovered. And when you go into these school board meetings, sometimes they could be really contentious. And that was certainly hurtful and disempowering for me as a parent. I saw it in my father, who was world renowned as he was a physician and a lawyer who worked for mentally ill patients and who were involuntarily committed to hospitals. But when you look at his life, he grew up basically on the equivalent of a chicken farm in Brooklyn in the 1920s, and his parents were illiterate. I remember he told me a story about how he read a lot and he wanted to go to a high school. And then there was a guidance counselor who looked at him, and my dad never had a lot to eat and he was gaunt. He was constantly having episodes of conjunctivitis. I imagine he looked at this scrawny, red-eyed kid in front of him and he said to him, "Son, if I were you, I would just focus on getting a vocation. I don't see any good for you to go to a high school." So I've heard about these things of disempowerment and how it fuels people. So it was something that was definitely percolating below my experience when I wrote it. I think it's helped me become a more empathic physician, but it was something that surprised me. I mean, I'm glad that patients are finding this book to be empowering as well as like learning about medical details.
Yeah. Yeah, I think it, first of all, helps humanize you to know that I think sometimes as a patient, we can feel like our doctors are just like, they exist. It's like kids think of their teachers as like only existing at school.
Yeah.
You think of your doctor as like only existing at the doctor's office, and that you're a real human being having your own challenges and ups and downs, just like us as patients. It's not like an us versus them, but yeah, I think it is being, I would speak for myself in that it feels at times disempowering. Navigating the healthcare system can feel intrinsically disempowering at times when you find out that, okay, my doctor wants me to take this medication, but now there's going to be all these insurance barriers. Starts trigger warning to everyone who's experienced this, and that maybe you find out there's all these things outside of your control, maybe, that are going to affect your access to care. But that said, there's always going to be, like, when I'm overwhelmed, I always think to myself, okay, I start like literally making a chart in my head, like, what can I control? What's in my zone of control? What's in my zone of influence? Maybe not full control, but I can influence it. And then what's out of my control? And that helps kind of ground me. And then, okay, there's always something in my control. And I think that's empowering as a control freak.
Yeah. And I always think when you go see a new physician, it could seem overwhelming. But one of the things that I tell patients is actually it sounds a little bit weird, but they should rehearse their visit.
No, that's great.
Yeah. Yeah. Well, let's do that. I mean, when you rehearse your visit, the chronology actually goes easier and the visit is more efficient. But what happens is, like, when you rehearse your visit, you want to practice like who you are and, what you want out of the medications. And it helps. So I've had the 2 points I give. There was one patient of mine who was a fly fisherman, and he loved going in streams and fishing. And the rheumatoid arthritis was affecting his fingers, and he couldn't put the bait on the hook. So that told me, like, we would want to be more targeted and aggressive to knock out any degree of joint pain. And then there was a woman who came in diagnosed a little bit later on in her 70s, and she didn't necessarily want disease perfectly controlled. She would be happy what we call low disease activity. If there was certain inflammation, maybe still 1 or 2 joints, but as long as she could hold up her grandson without a fear that they were going to drop her. So again, when you create these narratives for yourself and unveil and opening up yourself, who you are, to your physician, it's a very compelling narrative. And I think that it helps you build a empathic bond with your physician.
I love that, because it's like a 2-for-1 deal, because you're informing, as a patient, I'm informing my provider as to the functional impact of my condition, right? I can't do my required tasks of putting the bait on the thing or holding my grandson, but you're also then implicitly communicating to your provider your humanity, and that you're not just
Right.
a series of tissues. You're a human being, and that makes it just forges a connection. Yeah, I had a patient on recently on the podcast who said, I just love the way she said it. She said, I plan for my doctor's appointments like I plan for a business meeting. Think of what
Right.
you want to say, get your bullet points out. What are some other practical tips or just general tips for patients to become more empowered? I mean, we have rehearse, revisit. We have, I think, foundational one that's covered in your book is like learn, or I have my own like self-paced course, which is like a video book where it's like Room to Thrive, which is like learning about your condition, learning about the tools to manage it, learning basic self-management. That would be another one. What are some others?
Well, so I think actually making yourself vulnerable in the sense of really showing it an intimate. I had a patient, he was this big strapping guy, and he was 6'5", and he would always show up to his visit, and he would always say he was fine. And one time his wife came to the visit, and he's, how are you doing? And I said, I'm fine. And she looks at him and was like, what are you talking about? You're crying like every morning before you wake up. And I think that, and then I saw him differently. But yeah, I think that making yourself vulnerable, if possible, as much as you feel comfortable, that also really helps physicians into your life. I think that's important. I think it is important. Empowerment is through learning about the disease. And there's so many different opportunities. There's disease foundations, there's support groups, there's websites. So I think empowering yourself from that standpoint. So I think that rehearsing your disease, showing what you still want out of life, making yourself comfortable so you can really have a heart to heart with your physician, that's emotional resilience. And then when you combine that with learning about your disease in different venues, you're going out a way to making yourself as a compelling patient.
I love that. I have a related question. Sometimes, so I teach people about the topic of symptom tracking, how that can be a helpful tool. Sometimes it can be a harmful tool if we become obsessive about our tracking and kind of track without thinking about what's the point of it
Right.
but I've had patients tell me, well, I'm worried that if I bring my symptom tracking journal to my doctor, they're going to be like, I don't even have time to look at this, or like that they have anxiety about sharing their tracking with their physician. What do you say? Do you find it helpful when your patients come to you with their trackers?
It can be very helpful. So I have some friends who are, and this is not to say that patients with inflammatory arthritis, it's in their head, but I know that patients who seek providers for depression, there's like a depression chapter. Like my mood was a 0 out of 10 that day. That night before, I got like 4 or 5 hours of sleep. And did I feel too high or too low? So I think it is helpful, or you don't want to be overly detailed because that's going to detract from the visit. But if you have like a journal on a day-to-day, like today overall, I felt for a 0 out of 10, and today is how much pain I was in, a 0 out of 10, and today how many joints were hurting me, a 0 out of 10. So even it sounds like that's just on the surface, and you want that just to provide a covering, because at the end of the day, you want your physician to listen more to you and focus on your symptoms. But I do find that from the day-to-day changes that you experience, that bringing such a tracker to your physicians can help.
Yeah, that's good to hear. And yeah, I don't know how many other people are like me, but I do tend, what I've noticed, and my doctor had to call me out on this gently, was that I think there's some people that underreport, there are some people that overreport their pain potentially, and some people like me underreport our pain. So I want so badly for everything to be okay that I'll be like, oh, it was fine. It was fine. And then she has to be like, was it really? And so and it's not that I'm like literally like incapable of lying. Like I'm just like the most like straightforward, like honest person ever. But it's more like my lying to myself. Like I'm like, oh, it's okay. Like after, anyway, my postpartum flare up, if I could do something differently, I would have been more attentive to the fact that I was kind of disassociating from my body because I kept just wanting it to get better. So I kind of wasn't paying attention to it. And the inflammation, the pain, the swelling, I was like, it's fine. It's about to get better. It's about to get better. And then we had to have this like come to Jesus moment where she
Yeah.
if it was going to get better, it would have gotten better. And so we had to switch medications at that point. But anyway, so knowing that if I wish I had, at that point I was so overwhelmed and with taking care of a baby and taking care of myself. But if I had like some sort of app, like now there's all sorts of apps. This was like over 10 years ago. There weren't symptom tracking apps that I knew of at the time, but that could have like pinged me a couple times a day and made me force me to say, what is your joint pain or swelling or tenderness at this moment? It would have forced me to actually realize that it's there and that I would have communicated that to her versus being like, that's probably a 1. I don't know.
But it's natural because I think there's a tension between wanting to be like optimistic, but then there's a tension of also realizing that there are parts of you that are hurting and suffering. And so there's a real tension in how you can honestly describe your symptoms to your physician without being so deflated that your sense of hope is gone. So I think that's a natural tension there.
Yeah, there's a concept that Lauren, who she's a virtual assistant for me in my business, and she also is she's about to graduate with her occupational therapy degree. She also has lived experience with arthritis, and we kind of have this concept overall with all of my content as being realistic yet hopeful, or finding like a sense of realistic hope, like not just. I think a lot of people who are on social media in particular are kind of defining the only hope as hope that you're going to heal or cure your condition or get it completely perfectly controlled, which sometimes that is realistic, right? Especially in the early days, more mild disease. But other times it's like more helpful to say, okay, like my realistic hope comes from the sense that I will be able to cope with and thrive despite whatever is going on in my life, whatever challenge it is, if it's arthritis or anxiety or dealing with other things out of my control. So if that's helped, I don't know where I came up with that.
No, I think that's great. No, it's great because I think that there could be like focus on the granular level is looking at scales like, is my disease active? Is it a little bit active? Am I in remission? And, but that has to be juxtaposed as well. What can you do and how do you feel? And are you feeling better or worse? And not getting caught up in something. So I think the physicians, we could go and say this is remission, low disease activity. But I think that goes back to what the patients tell us, like, this is what I hope for. You told me this is what your goal was, let's say 2-3 months ago. Are you there? And again, always bring it back to the patients. And that's what makes it interesting because every patient will just find success in many different ways. And that's the fun of caring about patients because it's not formulaic. You really have to listen to patients as individuals, and it's really important.
Yeah, I do think that is one of the things that in occupational therapy, it's very similar. It's really customized to the patient in their specific life context. So, oh my gosh, I can't believe we have to actually already get to the rapid fire questions.
All right.
Yeah, well, I want to first say, is there any hot topics or are there any hot topics in the field of rheumatology that are exciting to you at the moment?
Yeah, well, what's really exciting to me is that we're basically entering the era of precision medicine, and what that means in a very broad way is that when you come, even during your initial visit, the physicians will be able to tailor care towards you as an individual. We don't know 100% of the time which medications are going to work in the beginning, and we might have to try a second one. When in precision medicine, the hope is that we'll be able to look at the products of your genes and be able to customize a medicine for you very early in the treatment process.
That's going to be I'm really excited for that. And everything you've said so far is helpful to somebody newly diagnosed. If you just had to give one message to somebody who's newly diagnosed, what would you say with rheumatoid arthritis, let's say?
Let's say, think of this, that we are in a golden era of inflammatory arthritis, and we're really entering a cusp where there's so many different medications where precision medicine, like I just talked about, is there. So I think there's a lot of reasons to be hopeful right now.
Yeah, I love that. I feel very lucky to be diagnosed in 2003. I got in just under the wire to get on enroll in methotrexate right away. Do you have a favorite like mantra or inspirational saying that just gets you through tough days?
I do. It's from The Office. It's from Andy Bernard. It's actually right here. I was going to say, I wish there was a way to know you're in the good old days before you've actually left them.
Yes.
Just appreciate the present moment and not just be nostalgic for things that have passed.
Wow, I needed, yes, I needed to hear that today. I'm sure other people are listening. Now, this is kind of the $100,000 question here, or maybe with inflation, $1 million question. But what does someone living a good life and thriving with rheumatic disease mean to you as a provider?
Or it means knowing from a realistic perspective that you do have a rheumatic disease, but also knowing in the same breath that you're someone with a disease that have lives that of your own that can be helped by rheumatic diseases. It's the disease in general, but it's against you as an individual patient. Just you're a patient and you're not just a nameless person with a disease. I think that's helpful.
Yeah, really recognizing your humanity, and it doesn't, I think, sorry, I'm going to expand on this, but one of the things I didn't expect when I started running support groups for people with rheumatoid arthritis in 2020 was that this concept of ableism would come up a lot, whether or not it's named as ableism and internalized ableism. So just like racism is like discrimination against people in specific racial groups, ableism is discrimination against people with disabilities or health conditions. And I think there's a lot of people that automatically believe that they are somehow, their personhood is threatened when you have a diagnosis, that you are less than, and that therefore the only way to become whole again is to heal or cure your condition. And the only way to live a good life is to be 100% healthy and able-bodied, which is really a limited perspective, given that actually disability is the only minority category that anyone can enter at any time, right? There's just healthy lifestyle can move the needle, but there are no guarantees, as we all know, right? There's babies that die of lung cancer. They've never smoked or done anything. It just happens. So I think for me, confronting my own internalized ableism and realizing that, I refuse to think of myself as less than because I have this diagnosis, that has been empowering. There's that word, empowering. So for what that's worth, if that's helpful. And I know we've again mentioned, I want to mention again the name of your book, The Living Well with Autoimmune Disease, a Rheumatologist's Guide to Taking Charge of Your Health. Very helpful for all autoimmune conditions or autoimmune. I mean, I think fibromyalgia is included in there. I think there's like a debate sometimes I think it's not really known if fibro is autoimmune, or is it known now?
I don't think it's known. It shows that because I think patients with rheumatoid arthritis, like in the beginning, especially 40% in their first year have fibromyalgia. So it could be associated with depression and fatigue and brain fog. So that's why I brought it into. I mean, I also talk about diet. I talk about depression. I talk about the primary autoimmune diseases. So there's different things that kind of alternative treatment type things that work its way into the book as well.
That's huge. And that's a big, if we talk about that sphere of control versus sphere of influence, that is a lot of the lifestyle stuff. Not all of it can be under your control, but it is empowering to think, okay, can I maximize my sleep today? Can I choose to put my phone outside of my room so I don't look at my phone before I go to bed?
It's all the things that I tell my 10 and 12-year-olds with varied successes to get their phones.
Oh, you know what we're doing? And it's for the 44-year-old, me, and my 11-year-old, is we're buying a phone jail. We're buying a phone jail, and he doesn't have a phone, he has a watch, and he knows it's supposed to be on the charger at night, but sometimes there's a little pitter patter of little feet that have gone over to get the watch out to text the friends that we realized recently. So we're like, you know what? And I'm going to practice what I preach. I'm putting my phone in phone jail every night. So I don't know if you've seen these. They're literal like containers that you physically.
I have not, but I will look.
Okay, we got to talk offline about that because that's, and I did have replacement behavior. So my whole life, one of the only things one of the only habits that I've been consistent about, or just something that's been with me since I was a young child, is I love to read before going to bed. I've talked to people at this point will have listened to, if they listened to the episode with Carrie Bradshaw, marathon runner, the first person ever to finish a marathon with double hip replacements from congenital hip dysplasia. Anyway, she's a really cool person. I mentioned it in her episode too. But anyway, Ever since I was little, I would always read before going to bed. I'm joking. My husband has a picture of me with my Kindle on our honeymoon in Fiji. Like, I'm always doing this. This is my habit. Okay. But during the pandemic, I didn't even consciously realize this, but I started scrolling my phone. Oops, I raised my hand somehow. I scrolled my phone instead of reading books. And I started scrolling for a couple years. I would be like, oh, I'm just going to scroll a little bit and then I'll read, but then I'd be too tired to read because I'd be scrolling. So I was like, oh my gosh, I've broken this like beautiful tradition that I've had since I was little of reading before bed. So then I put my phone outside of the bedroom. And so I started again, maybe 2 years ago, reading again. Anyway, so that's been helpful for me because it's something I can do kind of laying down that's relaxing, but I'm not getting into the whole thing about scrolling is that there's all these algorithms that have figured out how to get you to keep scrolling and not stop. Whereas a book is a one cohesive story that you're reading. So anyway, if anyone else is struggling with that, get a phone/device jail you can set it for, I don't know. I'll send you the link to the one I'm looking at. I haven't gotten it yet. And anyway, so yeah. Okay. Back to the other thing. So yeah, is there anything else you wanted to share before we wrap it up? It's okay if there's something else.
No, I mean, that's it. I love care for patients, and I hope that comes across in the book. And I think it'll help patients. So.
100%. I want to do a giveaway too. So I have purchased a couple copies of it, and I'm gonna have, when this episode comes out, I'll do a little giveaway of one of them because I do believe in the message so much. And thank you so much for taking the time to share it here. Your passion definitely comes through. Like,
thank you.
Yeah. And your website where people can find you, you're not really a social media guy, right?
Yeah, or just my website.
Or just JuliusBurnbaum.com.
Yeah, designed by my son.
Oh, fun. The 17-year-old? Yeah.
No,
that's
that was
great.
a 15-year-old. Yes.
The 15-year-old. Okay.
Yeah.
Oh, awesome. Okay.
Yeah.
No, they did a great job. And really, you have a very busy schedule. You're high in demand. You're the only person who is a rheumatologist and a neurologist. So I appreciate you taking the time today to share your wisdom with our audience. And again, I'll put all links to everything we talked about in the show notes, which you can find on my website, the Arthritis Life website, which is myarthritislife.net. So thank you so much, and we'll talk to you later.
Thank you.
Thanks. Bye. Thank you so much for listening. This podcast is supported by Room to Thrive, an educational program I created to help empower you to live life to the fullest with rheumatic disease. In the program, you're going to learn evidence-based tools for managing all the ways rheumatic disease affects your life. And my goal is to help you go from overwhelmed to confident, supported, and connected in a matter of weeks. You can go through the pre-recorded modules on your own in the self-paced course, or you can take the course along with a robust support group of new arthritis friends to support you and cheerlead you along the way. Learn more in the link in my show notes, or you can always go to www.myarthritislife.net. And if you like this podcast, I'd be so honored if you took the time to rate and review it. I also encourage you to share it with anyone you know who might benefit from it. I also want to remind you that you can find full transcripts, videos, and detailed show notes with hyperlinks for each episode on the Arthritis Life website, plus full episode videos on the Arthritis Life YouTube channel. If you have any ideas for content for future episodes, or you want to share your story on the podcast, please send me, Cheryl, an email at info@myarthritislife.net. I can't wait to hear from you, and thanks so much again for your time.